Hello one and all. Today we're going to discuss about the topic of biomechanics of knee joint. This is nothing but a picture representation of knee joint, which comprises of femur, tibia, fibula, patella, meniscus, collateral ligaments, that is lateral and medial meniscus, and lateral collateral ligament and medial collateral ligaments. And the contents which we are going to discuss about in this video is introduction, function, tibiofemoral joint and patellofemoral joint, articular surfaces, capsules, ligaments, menisci and muscles around the knee. Coming to the introduction, knee joint is one of the largest and most complex joints, as we all know, and it gives major stability and mobility. Functional shortening and lengthening of the extremity by flexion and extension is done by the knee joint, and it supports the body during dynamic and static activities, whereas in closed kinematic chain supports body weight in static erect posture, whereas in dynamically it provides support body in sitting and squatting activity during locomotion. Type of joint. The type of joint is double condylar joint. Degrees of freedom of motion is, as we all know, flexion, extension, medial and lateral rotation, adduction and abduction of knee joints. And this is nothing but articular surfaces, which comprises of articular cartilage, ACL, PCL, lateral meniscus and medial meniscus, as we seen in the first slide. And articular surfaces. Yes, the proximal articular surfaces comprises of femoral condyle, medial condyle, which is larger than the lateral. In distal articular surfaces, it comprises of tibial condyles, medial and lateral. Now coming to the alignment of knee, the anatomical axis of femur is oblique and directed inferiorly and medially. The anatomical axis of tibia is vertical. Coming to the alignment of knee, normal knee forms a lateral angle of 170 degree to 175 degree. Coming to the variations, genu valgum or knock knee, that is lateral angle when it is greater than 170 degree, and genu varum when the angle is of about 180 degree. It is also known as bow-leg angle. Yeah, this is the representation of genu valgum knee, and this is a normal knee, as we all have, and this is genu varum knee. Coming to the menisci, we're going to discuss about the fibrocartilaginous disc, functions, blood supply and mechanism of injury. Coming to the functions, as we all know, menisci improve the congruence of joint, and it distributes the weight bearing forces, and it decreases the friction between tibia and femur, and it is also a shock absorber. Nutrition. Yes, during the first year of life, it contains blood vessels throughout the meniscal body, and as the age increases, the vascularity decreases. Outer 25% of is vascularized by the capillaries from joint capsule and synovial membrane, and central blood supply is by the diffusion from the synovial fluid. So, what happens by prolonged immobilization or non-weight bearing? Let's see. So the menisci does not receive appropriate nutrition. Avascular nature of central portion of the meniscus reduces the potential of healing after injury. In adults, only peripheral portion of the meniscus is vascularized, hence it is capable of inflammation, repair and remodeling after injury or tear. And coming to the compression forces at the knee, while walking, 2.5 to 3 times the body weight, whereas in ascending stairs it is about 4 times, whereas the menisci triples the surface area by significantly by reducing the pressure on the articular cartilage, and lateral meniscectomy increases the pressure at the knee by 230%. And coming to the mechanism of meniscus injury, it is forceful rotational of femoral condyle and partially flexed and weight-bearing knee, locked knee syndrome. Medial meniscus is injured twice as much as the lateral. Risk of meniscal injury increases with instability. Yes, test. What is the test for meniscal injury? Is Apley's grinding test and Mike-Murray test. Coming to the capsule and ligaments, it comprises capsule, collateral ligament and cruciate ligament. Coming to the capsule, it comes under 2 layers, the fibrous layer and the synovial layer. Yeah, the fibrous layers has 3 layers: the extensor retinaculum anteriorly, the facial layer, that is distal quadriceps muscle, and deep medial and lateral retinacula. Coming to the synovial layer, the internal surface of the capsule is lined by synovial membrane. The role is secretion of synovial fluid, absorption of fluid into the joint for lubrication, nutrition to avascular structures like menisci. Yeah, this is collateral ligament, MCL and PCL, that is medial collateral ligament and the lateral collateral ligament. Medial collateral ligament, it originates from the medial epicondyle of femur and inserted into the medial tibial plateau, medial meniscus, medial proximal tibia. What is the function? In the sense, it restrains excess abduction and lateral rotation stress at knee. Yeah. Injury when valgus stress is delivered over the planted foot, common in football players. MCL is rich in blood supply, hence has good healing. Coming to the lateral collateral ligament, it originates from the lateral femoral condyle and it is inserted into the fibula head, and it checks wear stress and excessive lateral rotation of tibia. Coming to the cruciate ligaments, it has two cruciate ligaments, anterior and posterior cruciate ligaments. So this one is anterior cruciate ligament and this one is posterior cruciate ligament. Yeah. Its inferior attachment is into the anterior tibial spine. It extends superiorly, posteriorly to attach to the posteromedial aspect of the lateral femoral condyle. It has two bands, that is anteromedial band and posterolateral band. And it functions as restrains anterior translation of tibia on femur, and it prevents hyperextension of knee, secondary restraint against varus and valgus motion. Coming to the mechanism of injury, that is ACL, it is most common injury, happens mostly in football players, downhill skiing, basketball and soccer players. The mechanism is common in weight bearing, slight flexion and rotation in either directions. So anterior translatory force and proximal tibia, hyperextension injury, hyperflexion and bulky lower extremity muscles. Coming to the posterior cruciate ligament, it originates in the posterior intercondylar area of tibia as we have seen before, and insertion in the lateral side of medial femoral condyle and anteromedial and posterolateral bands it has. And its function is primary function to posterior translation of tibia on femur, and it limits the anterior translation of femur over fixed tibia in activities such as rapid descending into the squat and landing from jump with the partially flexed knee. And mechanism of injury is nothing but pre-tibial trauma, hyperflexion and hyperextension. That is nothing but a dashboard trauma in thin individuals, second ligament to be injured after ACL. And muscles aiding in tibial translation is nothing but quadriceps and gastrocnemius in the anterior translation, whereas soleus and hamstring in the posterior translation. And other ligaments include oblique popliteal ligament, anterolateral ligament. Yeah, bursae. So there are 14 bursae, reduce friction between the intertissue junction during movement. Activities that involve excess and repetitive force at the intertissue junctions frequently leads to bursitis. The bursitis is nothing but there are suprapatellar bursa, prepatellar bursa and infrapatellar bursa. The prepatellar bursa, if infected or if inflamed, it is said to be as housemaid's knee, whereas infrapatellar bursa is inflamed, it is said to be as clergyman's knee. This is patella and this is prepatellar bursa, infrapatellar, deep infrapatellar bursa, and this is infrapatellar bursa. Yeah, this is plica. As we are seeing, this is superior patellar plica, this is middle patellar plica, this is inferior, and this is ACL, anterior cruciate ligament. Yeah, what is plica? So coming to plica, synovial membrane formation occurs in early embryonic development. So synovial membrane separates as medial and lateral articular surface, that is into separate cavities. By 12th week of gestation, synovial septate reabsorbs to form a single joint cavity. Sometimes failure of complete reabsorption results in persistent fold called plicae. So plicae gets infected or inflamed or irritated. That is said to be as plica syndrome. Yeah, these are the summary which we have seen before, and these are the references. Thank you.